So again, good morning again, good afternoon, and good evening to everyone, depending on the part of the world you're joining us from. And warm welcome to this Prevention Collaborative webinar. We're really happy and excited to be with you for the next 90 minutes. So thanks for the time you made to be with us. We really appreciate. I am Rita Nyiratunga, based in Kigali. I'm a senior associate with the Prevention Collaborative, and I am privileged to be the moderator of today's webinar. And for those of you who may not be familiar with the Prevention Collaborative, we are a global and virtual network of researchers, activists, and practitioners that aims to strengthen programming in the area of prevention of violence against women, with a particular focus on intimate partner violence and violence within the family. We also give a particular attention to programming around the intersections between violence against women and violence against children. We work to strengthen the capacity of key actors, including ourselves, to design, deliver, and advocate for cutting-edge prevention programs informed by research-based evidence, practice-based learning, and feminist principle. Today's webinar is the third in our series of VAC webinars. And Bandebereho, which will be the focus of the day, is one of the programs that have been effective in preventing both. So we're really happy to have great speakers to share with us about Bandebereho. Before I introduce our speakers, I'd like to share a little bit of housekeeping matters so we can communicate and collaborate better during this webinar. Right? I know we used this virtual world now, but let's go quickly through this housekeeping. So I would like to let everybody know the webinar is being recorded and the recording will be shared. And if you do want to say something at a point and do not want it to appear in the recording, feel free to let us know. We'll take care of that, all right? We'll also have time for question and answers, but if in the course of the presentation you have a question, feel free to share that in the chat box and we'll address it when time comes. We do recommend that you direct your question to all panelists and attendees so we can all share at once. You'll also have the option to raise your hands using the blue button that you can see there. I know you're familiar with that by now. And we will call on you, that's during the question and answer section, and we will unmute you to ask your question out aloud. Well, like I promised today to speak about Bandebereho, the long-term impact and scale up in Rwanda under COVID-19, we have colleagues from Promundo and RAMREC, and I'll quickly introduce our speakers. Together with Kate Doyle, who is a fellow at Promundo with more than 10 years experience as a leader, program developer, and implementer. Kate has conducted research on issues of gender, masculinity, HIV, and health services. Her work focuses on the prevention of violence against women and children, women's economic empowerment, and reproductive, maternal, newborn, and child health and rights. Thank you so much, Kate, for being with us today. We also have Debolina Rakshit, who is a research officer at Promundo. She supports research across all Promundo's key areas of interest by contributing to data analysis, report writing, technical support to partners, and design and implementation of program monitoring and evaluation tools. We really appreciate the time you made to be with us today, Debolina. You're most welcome. We also have Emmanuel Karamage, who is the Bandebereho coordinator at RAMREC. He's based in Rwanda. He leads the scale up of the Bandebereho intervention through the health sector in Musanze district, one of the 30 districts of the country. So he has over 10 years of experience as a trainer, an implementer, a mentor in promoting gender equality and gender-based violence prevention. Emmanuel also engages men and boys in services to promote maternal, newborn, and child health and sexual reproductive health and rights. Okay. So today, if you go on the next slide so people can see the connection that we have. Today's webinar actually is the third and the last in a series of 3 webinars we hosted. And on VAUVAC. And if you want to catch up on some of those webinars, please do visit our website and you'll be able to get the links to the webinars and watch at your own pace. And I know my colleague will be pasting some of those links in the chat box so people can access it easily. So without any further ado, I'll hand over to our speakers who will take turn without me coming back again. So thank you all for your listening and we look forward to the next discussions. Over to you, Kate and colleagues.
Thank you, Rita, and I hope that you can hear me all right. We're very excited to be back here again, presenting for the Prevention Collaborative. We had the chance to present a few years ago, which some of you might have seen, an initial webinar explaining a little bit about the Bandebereho program, which stands for Role Model, and some of the original randomized controlled trial findings that we did to assess its impact. And so we're really excited to be back again and sharing a little bit more about what are some of the longer term sort of 5-year impacts, as well as how we're working together to scale up the program through the health sector. And so Promundo and Ramrak have been working closely together on this program since about 2013. And my role before handing it over to my colleagues is to give you a little bit of context to put the new study findings and scale up into context. Next slide, please. So Bandebereho is a gender transformative couples intervention designed for parents of children under 5 years old. So it is a small group education intervention which uses fatherhood as an entry point. So recognizing that, the transition to becoming a father is an important opportunity to be able to work with men and engage them in reproductive, maternal, newborn, and child health, to engage them in preventing violence against women and against children, to promote their engagement in caregiving, both childcare and household tasks, and a really critical opportunity to promote healthier couple relations, like couple communication and equitable, sharing of household responsibilities. Next slide, please. And the intervention is really informed by, the knowledge that parenting and health seeking and relationship behaviors are deeply influenced by gender norms. And so it uses a structured either 15 to 17 session curriculum to really engage participants in critical reflection and dialogue, on how gender roles and inequitable norms influence what it means to be a man, what it means to be a woman, and how that influences particularly couple relations and parenting behaviors as well. And it's really designed through participatory activities, group discussion, information sharing, to be able to equip parents with information and skills and encourage couple communication. So both by working with couples directly in the sessions to provide opportunities to communicate, whether that's about, parenting, whether it's about household budgeting, about, priorities for the family, but then also through encouraging, couple communication at home after the sessions end. And it really strives to create a safe environment, with peer support to be able to practice new but more equitable behaviors. And it is an intervention that is designed specifically to engage men, so it recruits through the male partner, and men are invited to all of the sessions, but women are invited to a portion of the sessions, which are couples sessions. And the number of those has varied over time between sort of 6 and 8 sessions for couples to sort of now 10 sessions for couples in the scaling up version. Next slide, please. And just to give you a little bit of context, sort of the timeline of where we are now, the intervention was sort of designed back in 2013 based on formative research, adapted from Promundo's Program P, curriculum that was first developed in Latin America. So through a sort of 6-month process of trying to make sure that it was culturally relevant, tailored to the needs and the priorities that men and women in 4 different districts of Rwanda sort of shared with us that they would like to see in this curriculum. And through government approval of the curriculum itself, following sort of participatory adaptation with both Ramrek staff and with community members in those 4 districts. And then over the subsequent 2-year period, we sort of piloted this intervention, Promundo and Ramrek, by training fathers in local communities, so lay facilitators, to recruit and facilitate the sessions with couples in their local communities. And over that 2-year period, about 1,728 couples were reached. And in the sort of 3rd cycle of implementation, we felt it was really ready to be sort of rigorously evaluated. And we were quite lucky to be able to get specific funding to be able to conduct a randomized controlled trial to sort of assess the impact. And I'll share a little bit of insight into what some of those findings were in just a minute. And then based on sort of what were very positive findings and a lot of positive feedback from the communities in which the program had been implemented, as well as the local district authorities and the health sector, there was a lot of desire to scale up the intervention and keep it going. So we collaborated on planning and fundraising to be able to deliver at scale and examine how would we deliver it at scale and through what means. And that was really led by the partnership of Promundo, Ramrek, and the Rwanda Biomedical Center and the Ministry of Health, with support from a multi-sectoral technical advisory group. And then sort of the period of 2019 to 2021 is what we call sort of the transition to scale phase, testing the delivery of the intervention at scale through the health sector. And it's also the period in which obviously the COVID-19 pandemic has hit the world. And so we were lucky enough to be able to conduct a study to look at some of the impacts of that. And we're going to share a little bit more about that. Next slide, please. And so just to give you a little bit of context for the Bandebereho RCT, which was conducted beginning in 2015 through 2016, a 2-arm randomized controlled trial, so randomized at the individual level due to the design of the intervention, but with 1,199 couples. So, approximately half of the couples were randomly assigned to participate in Bandebereho in their communities, and roughly half were assigned to a control group which received no intervention. But all of these individuals and couples met the eligibility criteria for the intervention, which was that they were married or cohabiting partners who were either expecting a child or had children under 5 years living with them, and lived in the sites where the intervention was being implemented. We did 3 rounds of data collection in the original RCT, so baseline, obviously, before the intervention began, and then a 9-month assessment and a 21-month assessment. So, 4 months after the intervention had ended, and then again, 16 months after the intervention. And we were quite lucky to have quite high response rates at all of those 3 points of data collection. And then sort of moving to where we are now, sort of 66 months later, or 61 months post-intervention, so about 5 years after the intervention ended, we did a follow-up study during the COVID pandemic. And Debeline and I will be sharing some of the findings and methodology of that a little bit later in the presentation. And then we're very, very lucky to be also able to do a 6-year follow-up of the RCT, which is currently in the field with data being collected despite sort of challenges presented by the pandemic, which is also aiming to strengthen the findings around early childhood development as well. And I would be remiss if I didn't mention that, we've been lucky to have quite a number of funders who have supported both the intervention and the evaluation over time, starting with the Dutch Ministry of Foreign Affairs, the MacArthur Foundation, the UK Work and Opportunities for Women Fund, Anonymous Donors, Echidna Giving, and the Oak Foundation. Next slide, please. And basically, I'm not going to go into the details of the randomized controlled trial. We've been lucky enough to present that before, and I think Ruti is sharing some links to resources where you could find out more information about that. But essentially, we were really encouraged to see that with this one intervention, we were able to impact multiple gender and health-related outcomes. So sort of this is a quick snapshot of what some of those outcomes were, but violence prevention is obviously what brought all of you to this webinar, and we're very excited to see that there was, looking at 21 months at the data collection, comparing the control group to the Bandebereho participants, we saw about a 40% reduction in physical and sexual IPV. So women whose partners participated in Bandebereho were less likely to have experienced those types of intimate partner violence in the past year than women in the control group. We must say, though, that there was still about a third of women who in the intervention who were reporting some form of intimate partner violence. As well, we saw about a 15% reduction in parents' use of physical punishment, which was particularly encouraging because it was a very limited focus within the original curriculum. So it was really encouraging to see these findings of both, preventing violence against women and violence against children within the home. But we also saw, very critically, given our partnership with the Ministry of Health in this program, that the program was successful in both increasing women's antenatal care attendance, as well as men's accompaniment and participation in antenatal care sessions as well, which is already strongly encouraged in Rwanda, but we did see that there were significant differences among Bandebereho participants, as well as greater partner support during pregnancy and greater use of modern contraceptives. And beyond that, we saw important shifts in couple relations, so less dominance of men in household decision-making, whether that was related to finance or to decisions about contraceptives or to decisions about parenting. We also saw greater frequency of couple communication. And sort of finally, the intervention is strongly focused on engaging men in caregiving. And so we did see that men who participated in Bandebereho reported greater time spent, interacting with their children, providing stimulating care, so, reading with them, providing daily care for them. And they also reported, both men and women, greater sharing of these childcare and household tasks than couples in the control group. And this is sort of just to give you a little bit of a snapshot of why we were interested to scale this program up, is based on these findings and other outcomes. And we've got sort of a number of additional papers forthcoming that we'll hope you'll check out in the future as well. Next slide, please. And that takes us to really what we're here to share a little bit more about today, which is a follow-up of the Bandebereho RCT under the COVID-19 pandemic. So what we were calling care, coping, and connection under COVID-19. So I think, like many people and organizations in the last year, we were really interested to understand better how men and women were experiencing the pandemic and how this was influencing couple relations. Rwanda, like many countries, went into a pretty restrictive lockdown or confinement period quite early on in the pandemic. And like many people, we were concerned about potential risks of violence during that period, but also saw it as potentially an opportunity in which men might become more engaged within the household. So we were quite interested to examine this. And we were lucky enough that the WOW Fund, the Work and Opportunities for Women Fund, was interested in supporting us to conduct a study to examine people's experience under the pandemic. Next slide, please. And I think very encouraging, they were also open to our desire to actually attach this onto sort of the Bandebereho RCT. So to not only first understand how women and men with young children in Rwanda have experienced the pandemic and how that's impacted their couple relations, the distribution of unpaid care within the home, and sort of stress and financial strain and things that we know are related to potential risk for violence. But we were also incredibly interested to then examine the longer term impact of Bandebereho during this period of extreme stress. to understand whether couples who participated in Bandebereho 5 years ago might be experiencing the pandemic differently than couples in the control group, given all of the positive outcomes that we had seen in terms of, couple relations, communication, violence prevention, and men's engagement in unpaid care work. We really wanted to understand, have any of those outcomes been sustained during this period of extreme stress? So the study is taking place, 5 years after the intervention, and the 45 months after the last RCT data collection. Next slide, please. And I won't go too much into detail of the methodology. I think Ruti will be sharing the full report with you in the chat box. So we really hope that you'll download it and dig into it a bit deeper. But essentially, it was a phone survey. So, it was not possible, like in many places, to conduct in-person research, but we conducted a phone survey with 500 couples. So evenly split between the treatment group, so those couples who participated in Bandebereho 5 years ago, and the control group, in sort of the 4 districts where the Bandebereho RCT had originally taken place. Eligibility was restricted because it was a phone survey. So we looked at, men and their current female partners who were enrolled in the Bandebereho RCT. And then we had to restrict it to those whom we had a report that they had a phone, that they owned a phone at the last survey in 2016. And then that phone number had to be working as well. So we're, somewhat constrained to who we could involve in this study. But I think quite encouragingly, we were able to survey 500 men and 498 women. So all within couples. So both the man and the woman in the couple were interviewed. And we used this, a short survey, given that it was a phone survey, which included 16 questions. And the surveys were conducted by sex-matched interviewers from Laterite. So that's an external research firm, and the enumerators were not aware of, whether participants had participated in the Bandebereho intervention or not. And it's the same research firm that had conducted the 3 prior rounds of RCT data collection as well. Next slide, please. So obviously, to share a little bit about some of the ethical considerations. So we first started designing this study in April of last year, when there was a lot of uncertainty and, a lot of uncertainty, particularly about, what was appropriate to conduct, what types of questions were appropriate to conduct in a phone survey. And so we very much wanted to make sure that the survey was sort of following the guidelines that were available at the time around, asking people, for example, about experiences of violence. So we chose not to ask directly about, women's experiences of violence, but we did decide to ask about factors that we know are associated with violence. So quarreling, couple relationship quality, men's alcohol consumption. So factors that we know from other studies in Rwanda are associated with intimate partner violence, but also factors which some of our own analysis from the Bandebereho RCT data indicated are factors associated with violence. And so also I wanted to flag here that the Bandebereho RCT and the intervention itself recruit via the male partner. So they were always the first point of contact. And so when conducting this survey, we chose to first contact men, inform them about the survey and ask them if they were willing to participate, and ask them if they're willing to share the context for their partner as well. And this was sort of another step that we took just to make sure that we weren't just contacting women, and putting them potentially at a risk if their partner, happened to overhear a phone call that they were having. It was very important to us to make sure that this couldn't be a factor contributing to risks for women. And, the enumerators also made sure that people felt comfortable and were in a location where they could respond to questions easily. And we did receive research permissions from multiple different, ethical committees and institutions in Rwanda, which I will say, I think we were able to get some expedited review, but it essentially took about 4 or 5 months to get all of the permissions in place. So our initial desire was to sort of actually be able to interview people during the lockdown period or the confinement period. Next slide, please. But in fact, because we were a little bit delayed due to all of those permissions, we were sort of surveying people about 4 to 5 months after that period ended. So the surveys were conducted in August and September. And so we chose to then ask people to try and recall their experiences during the stay-at-home period or lockdown period in Rwanda, which was from the 21st of March to the 4th of May, but then also to ask them about their experiences at the time of the survey itself. And in both instances, asking them to compare to their lives before the pandemic. So, you know, how is couple communication in your relationship now as opposed to before the pandemic? Next slide, please. And here's where I'm going to turn it over to my colleague Develina, who's going to share with you, a snapshot of some of the findings, and we hope you will check out the full findings in the report.
Thank you so much, Kate. And hi, everyone. I'm very happy to be talking to you about some of the initial findings and some of the high-level findings from this new study that we have just come out with and that Kate was just describing. So as Kate was just describing the methods of the survey, we were asking respondents to think about the time of confinement when they were at home and comparing that to sort of the status quo before the pandemic. But there were also questions that were asking them to compare their new normal, so after the period of confinement was over, and sort of asking them to compare that to the status quo before to see if the new normal in some ways was resembling the old normal or were things shifting around. So to start off with some of these findings, we initially wanted to see how couples and households were really coping with and responding to the external stress that the pandemic and the stay-at-home orders really brought about in their lives. And perhaps not surprisingly at all, it had a fairly strong impact on households' financial situation. So whether a lack of loss of employment or loss of income temporarily at the time, most of our respondents who spoke with us said that they did report a worsened financial situation during the time of confinement. So 84% of men reported this, and 76% of women actually reported the same. And maybe the difference in the number might be explained due to the fact that men might have more sort of awareness of the of households' financial situation, and therefore a bit more concerned about the lack of financial stability at this time. There was a smaller minority of respondents who actually described their situation as having improved at this time. So it might have been due to the success of some of the government policies that were being implemented at this time to respond to the crisis. So employment generation program, other income support programs that we have some level of detail in the report on. So if you're interested in that, please do read the full report for more. But by and large, for most families, the time of the pandemic and the time of being sort of constrained to the home did prove to be a loss of income and a loss of financial stability. And this in itself is, of course, a risk factor for violence. The stress and the anxiety that arises from a worsened financial situation is of interest to us as a risk factor for violence in itself. But we also had specific questions to gauge how feelings of stress and anxiety and worry about the future was really being felt by couples. And this is something that we again see that even on a question about whether general levels of stress and anxiety had increased at the time of the survey, 70% of men and 63% of women, so more than 2 in 3 men and women basically did report feeling heightened levels of stress and anxiety at this time. We also had a specific question about whether there was stress around not being able to pay or meet sort of your basic needs. And that was, again, a question that men reported much higher levels of stress. So 62% of men reported feeling that level of stress against 49% of women. And this number probably points to sort of current social norms in Rwanda and elsewhere in the world that does still frame men as being the primary breadwinners or the financial providers in the household, and therefore sort of potentially more at risk of experiencing this concern at greater levels when there is when you're not being able to meet that normative expectation of being the financial provider for your household. There weren't very many differences between control and treatment groups here, but generally, the financial situation and stress and anxiety was being felt by a lot of households. And moving on to the next slide, please. Another factor that we were looking at as an indicator of stress and coping at this time was the use of alcohol. So because at the time of the confinement and also at the time of the survey, bars were still closed by and large, and bars being the main venue or access to alcohol, this did reflect in the use of men's alcohol having reduced quite a bit. So 86% of men reported that they were drinking less frequently at the time of the survey, something that their partners also confirmed. So it wasn't something that there was a lot of contradiction on, but basically, by and large, for most couples, alcohol usage was actually reduced. And again, we are interested in this because as Kate was mentioning earlier, alcohol use is a significant risk factor for intimate partner violence in Rwanda. And so we did want to get at that potential factor, even though we were not asking questions directly about violence use. What is concerning is that even though for most couples this was not the case, there was a small minority of about 5% of respondents where men said that their alcohol intake had actually increased in frequency compared to before the pandemic. And so when we look at specifically this group, and we wanted to sort of see whether there were associations with this, with worsening relationships and sort of more instances of quarreling and arguments in relationships. And we did find that relationship exist with, increased frequency of alcohol use being associated with 4 times higher odds of reporting increasing in quarreling with partners, and also 2 times higher odds of reporting a worsened relationships. So moving on to some of the other findings on the next slide, please. We were also looking to see how were couples at this time responding to this external sort of all these stresses that were coming because of the pandemic? How were their relationships really faring? And for many couples, this time actually proved to be a catalyst for further strengthening their relationship. So whether it was because of the additional time that they were finding to spend with each other, whether it was the experience of having to figure out how to make the best use of constrained resources, or just, the shared experience of experiencing a difficult time together. But for many couples, this was actually reportedly something that helped improve and strengthen the relationship. So about 53% of men and 59% of women reported that at the time when they were confined to the home, they actually experienced their relationship. They rated their relationship as being better than before. And this numbers go down a little bit at the time of the survey, but still more than half of men and women report that their relationship, even after the confinement period was over, was actually better than the older status quo before the pandemic. And other than the sort of general rating of relationship quality that we asked about, we also wanted to know about specific indicators of the couple's relationship, how it was holding, and also, again, potential risk factors, sort of proximate measures of violence in the relationship. So we asked about whether communication between couples around household decisions around finances, whether that had become more frequent or less frequent. And many couples actually reported that they were doing this more often at the time of the survey. So 55% of men and somewhat fewer women, 44% of women actually reported that they were discussing sort of household decisions and sort of communicating more frequently at the time of the survey. We also asked about instances of quarreling and sort of arguing between couples. And again, about half of all couples reported that they were quarreling or arguing less frequently at this time. We also asked about specifically feelings of increased frustration or anger at the partner during this time. 74% of men and about 70% of women reported that they were feeling this feeling of frustration or anger less frequently against their partner. and similar numbers for when we asked about their feelings of frustration around their children. And so, since we were talking about the intersections of violence against women and children, this is something that's, we find even in this study that there's quite a bit of correlation between respondents who say, who report feeling frustrated with their partners, also feeling that with their children. On the flip side of this, if we move on to the next slide, please, are that although for many, for majority of the couples, this time has proved to be one of bonding and of improving their relationships, there are still some risks present for a smaller group of couples where unfortunately relationships do indicate some deterioration. So at the time of the survey, at the time of when the lockdown orders were still in place, nearly 1 in 5 women felt that their relationship quality was actually worse than before the lockdown, and about 9% of men reported the same. These numbers worryingly actually go up a little bit at the time of the survey, so indicating sort of relationships worsening over time, with 12% of men and 22% of women, so almost 1 in 4 women actually reporting that their relationship quality had worsened at this time. And again, on the specific indicators that we were talking about sort of from the other side now, from the negative sort of point of view of reduced communication between partners, nearly 38% of women are reporting this, and about 24% of men at the time of the survey felt that they were discussing household decisions less frequently, making that a bit worrying for us. And also on the indicator around sort of quarreling and arguing, again, we see 17% of men and about 1 in 4 women who were reporting actually feeling that after the pandemic, they were still continuing to have more instances of argument and quarreling in the household. On the question about the frustration with partner, 1 in 5 men and women continue to feel this at the time of the survey, that they are actually feeling more stressed or frustrated or angry with their partner. Fewer numbers say the same about children when they were asked about their children. So about 1 in 10 men and women reported feeling this increased level of frustration and stress with their children. So even though, there was sort of, as we were mentioning, that because of this external extraordinary time of challenges, so even though it proved to be a positive sort of catalyst for many couples, there are still households and situations where we need to sort of be wary that there might be relationships that are sort of worsening and potentially violence increasing in some places. If we move on to the next slide now, we also had some questions to gauge the impact on care work and how that was being responded to at this time. So, I think none of us are a stranger anymore to the fact that the pandemic has indeed really increased the amount of time that households are spending on unpaid care work. And this is true of the respondents that we spoke to as well. So at the time of being constrained to the home, 80% of men and 73% of women felt that they were spending more time on unpaid care work than usual. And once at the time of the survey, when the lockdown wasn't as strictly enforced at the time, 55% of men and 46% of women continued to feel that they actually were doing more unpaid care work than before. And the reason for this might be that school closures and some other restrictions were still in place. So, potentially some of the additional care work was continuing on at the time of the survey. And then we were also, of course, interested in understanding how this was being distributed, this additional care work that had been generated at this time. And so it does seem that men have been at this time taking on some of the additional care work, whether sort of sharing it more equally or even doing most of the care work that was coming out of this time. But it is interesting when we look at sort of the differences between how men and women respond to this question. There is quite a wide disparity there. So if we look specifically at the response of women saying that it was they themselves who were doing a large part, or the most part of the additional care work. And we look at the differences in responses, women were actually 6 times more likely to say this than men were. And this is something that we find in sort of other settings as well, this sort of difference in perception of how the work is being shared and how that's being distributed and whether that's being equitable or not. And, you know, we care about care findings, of course, in and of themselves, but also, you know, we find, and I'll talk about this more on the next slide, but we also find that it is actually a factor around which relationships are worsening. So, you know, households where women seem to feel that the burden of care work or sort of the load of the additional care work is not being shared equally, that does seem to be a factor in the relationship quality worsening as well. And, you know, again, potentially as a risk factor for violence. So moving on to the next slide then, you know, after having sort of summarized in some ways, you know, how relationships are faring at this time, we wanted to look specifically at, were there certain factors that seem to be, you know, somewhat protective factors against worsening relationships and potentially increase in violence? And what were these factors that seem to have helped couples come out more resilient during this time and actually having strengthened their relationships at this time? And it does appear that, you know, households where they said that their financial situation during the pandemic actually improved, that was a fairly significant factor associated with multiple outcomes around improved partner relationships. So definitely not having that stress of worrying about finances and worrying about not being able to meet your basic requirements clearly is a big source of stress between couples. And when that's addressed and when that's taken care of to some extent, that does help the situation. Another thing that, you know, we sort of see is that when couples do communicate with each other, something that, as Kate was mentioning, is a focus of the Bandebereho program, for instance, but increased levels of communication between couples around household decisions, around using resources, is also, you know, in and of itself associated with an improved financial situation, but also helps, is correlated with improved partner relationships. So where couples talk more, you know, they also report being generally more satisfied with their relationship, which, you know, maybe is not that surprising. And then on the flip side of that, to sort of see what were some factors that were, you know, contributing to relationships actually deteriorating and potentially posing as risk factors to violence. Basically, you know, wherever relationships were breaking down, there was also increased levels of quarreling, reduced communication between couples, and more frustration with partners. So all of these indicators that we asked were sort of moving in the same direction and sort of correlated with each other, and sort of reporting generally a worsening of relationships there. And as I was mentioning in the previous slide, you know, where women were more likely to say that they were the ones taking on more additional care work than men were, that was another factor that was associated with also relationships worsening. So that inequitable distribution, or the perception of work not being shared equitably, is also potentially contributing to couple relationships breaking down in some ways. And then, you know, specifically for men who were experiencing worsened relationships quality, this was clearly something that was coming from the general level of stress and anxiety that they were facing. And this is something that we do see in the study as well, that the same men who were reporting sort of worsened relationship qualities were also the same men who were likely to say that they were sort of experiencing more stress and anxiety about basic needs, experiencing more levels of frustration in the home, and so on. And so that's sort of a very short snapshot of some of the factors that we saw were affecting resilience of couples and households. Moving on to the next slide, we wanted to really Sorry, if you could move on to the next slide, please. So we were also interested in seeing whether, program participants, so those couples who had 5 years ago had gone through the Bandebereho program, were they really experiencing the pandemic any differently from couples who had not gone through the program? And we see that, even though the external sort of sources of stress, so increased financial strain, so more likelihood to say that they were experiencing worse financial situations, or even things like the questions about general anxiety and stress, or even the questions about increased caregiving. All of these questions, there wasn't really any difference between how the program participants and the control group participants were experiencing the hardship. So the sources of external stress seem to be the same. However, in terms of the outcomes, in terms of how they fared in terms of their relationship and so on, Bandebereho couples do seem to have generally fared better on many counts. So they were, on some of these bigger sort of risk factors of violence, they were less likely than the control group to actually report these outcomes. So for instance, on the question about feeling more frustrated with your partner, those who were sort of the Bandebereho couples, they were about 14% of them said that they were experiencing this, whereas nearly 1 in 4, so 23% of the control group actually reported feeling frustrated with their partner. So that was a pretty big difference there. Similarly, on the question around frustration with children, about 9% of the program participants reported feeling increased frustration with children at this time, against about 16% of the other couples who mentioned this. So again, there's some sort of a difference in how, even from the external stresses, how it's being processed and how it's sort of playing into relationships with partners and children there. And even though, the alcohol use, as I had pointed out earlier, was fairly small group that had increased. If we look at the differences between the control and treatment group, it's actually about quite wide, the difference. So 1.4% of the treatment group actually reported increasing their alcohol usage, versus about 6% in the control group that reported the same thing. And we have some more findings on the next slide, where basically when we look at sort of the more positive outcomes around relationship quality and sort of sharing of care work, we see again that there is a difference between how Bandebereho couples have fared. And so if we look at just the quality of relationship question, we see that at the time of confinement, basically when couples were being restricted to their homes, 62% of the Bandebereho couples were likely to say that their relationship had improved, whereas about 49% of the control group mentioned the same. And these numbers changed a bit after sort of confinement had ended, but still the pattern remains the same, with 57% of the treatment group saying that their relationships had strengthened, against 49% of the other group that said the same. And very, relatedly, but basically a question about whether they were communicating with each other, whether the couple were really communicating amongst each other about household decisions. Again, 56% of the Bandebereho couples said this, against about 42% of the control group couples there. And finally, on the question around sort of sharing care work more equitably, we see that at the time of the confinement, about 77% of the Bandebereho group said that men were either doing an equal share or an additional, like doing most of the additional care work. And this difference remains there, although less significant at the time of the survey. So all of these are really encouraging findings that are suggesting that, even though it's been 5 years since the program, that some of our sort of some of the outcomes that the Bandebereho program really targets seem to have continued to have an impact on couples' lives, even during a challenging time like the pandemic. So, please do read the full report that I think the link has been shared already for more detailed findings. But I think this is a good time for me to hand it over to my colleague at RAMREC, Emmanuel, to talk a little bit more about the program and the experience of scaling it up with the government. So over to you, Emmanuel.
Thank you, Deborina. Thank you, Kate. Thank you, Prevention Collaborative, for this opportunity to share what we have realized in the Bandebereho program. Next slide, please. The Bandebereho, we are taking Bandebereho to scale the health sector, and the Bandebereho is engaging men in the maternal newborn child health, violence prevention, caregiving, and even in the ECD program. Next slide. We are in the health sector. We are looking to increase the availability and to reach more people in a sustainability way, and we are looking to reach the countrywide. And we are looking also to integrate this program in the routine work of Rwandan community health workers through the community health system, starting by the delivery of the program, the monitoring, evaluation, and the learning. This work is done in collaboration between the Ministry of Health through Rwanda Biomedical Center in the Division of Maternal and Child Health, Promundo, and the other government institutions such as ECP. Next slide. During this transition to scale, we are testing the feasibility of delivering Bandebereho via the health sector in one district. We are also exploring if the community health workers are able to deliver the program with quality and fidelity with a minimum of supervision. We are also adapting the training, the implementation, and the monitoring system, and we are generating learning to develop a national scale-up strategy with the support from Saving Brain Grant Challenge Canada, WOW, DFID Fund, and the other donors. Next slide, please. And one of the focus of this transition to scale, we are focusing on the purpose of the program remain the same, but also we are exploring the cost, the facilitators, the delivery, and even the monitoring change. The facilitators shift from the people selected in the community to the community health workers in the government structure, where we shift from one facilitator to two facilitators in the same group. And the session increased from 15 to 17 sessions, whereby 9 sessions was attended by the couples, and we focused more on power and unpaid care work for women economic empowerment. And during this transition to scale, there is no financial incentive per session, and the monitoring was done in collaboration with the government side, with the staff from the health center, combined with the Rwanda staff, with technical support from Promundo, but also with advisor from the Ministry of Health through Rwanda Biomedical Center. Next slide. During this transition to scale, with the engagement of government of Rwanda, we trained the 432 community health workers, and they have been recruited to conduct Bandebereho program in a small group of 12 couples, and 27 district and health leaders were trained to support the program in monitoring and even during the follow-up. And above the 700 local leaders from a village level, cell level, and sector level were trained to support the program from the recruitment, implementation, and even the monitoring. And the community health workers are reporting through the existing channel of reporting of government of Rwanda from grassroots level and to the health center up to national level. And this great work is supported by Rwanda and even the health center leaders and even the district leaders. Next slide. Next slide, please. Next slide. Sorry, go back, please. Can you go back? Okay, thank you. Okay, thank you. I was saying that we are focusing on the facilitation skills, and we are focusing on session length. And during this transition to scale, there is no financial incentive, and the monitoring was done in combination with the staff from health centers managed by government, and with the effort combined with the Rwanda staff. Next slide. No, sorry. Next one. During this transition to scale, we faced the issue of COVID-19 pandemic, but we learned that the Bandebereho, we can deliver Bandebereho through the health sector, as we reached the more than 9,000 parents were reached in at least in the past year, and the community health workers were trained to deliver the intervention with the high quality and fidelity, and with the consistency of a retention of community health workers. And therefore, we are looking how to scale the model at national level through the health sector of government of Rwanda. And thank you so much.
Great. Thank you so much. Thank you so much, all. Thank you, Manuel, Kate, and Debolina for such a rich presentation. And from the chat box, we can already see how people are interested, and thanks for sharing the resources. We'll all go and read into details these. So I'm just cautious of time because I know people may have questions that they need to ask and get clarification on, but I'm just really happy to see that after all those years, you were able to go back to Rwanda, maybe being a bit selfish. Rwanda is my country, and see the long-term impact. I won't take time because your presentation for me were clear and people can still ask questions if it wasn't clear, and we'll rather give time for the questions and answers. And if you want, we can start by people in the audience. If you have a question that you would like to voice, we'll give you time so you can ask a question or make a quick reflection, not just questions. And then we'll go to the other round of questions. Anyone who has a quick comment, a quick clarification? Oh, okay. Great. Anytime you feel like you have a question, feel free to raise your hand, and we'll give you time to voice your question. The way we do, we usually start with questions for clarification, so people can, start from the same understanding. And we have a question from Heron Abebe. Sorry if I mispronounced your name. I hope I tried. How was the response rate from the practical experience they have? Many people in rural areas are not comfortable about phone interviews. So that's a question of curiosity, and that was addressed to Kate. So Kate, do you want to take that one?
Sure, thank you. Yeah, I think there might have been a related question as well, which maybe I could tackle at the same time, which was sort of, I think, a first question about kind of what happened if a man did not give consent for his partner to be reached. And we didn't experience that. What we experienced was that, some men said, no, I don't want to participate in this survey. And because we were only looking to interview couples. If the man was not available, then we did not reach out to his partner, for example. And then with the response rate, so we did have about 194 replacements when we were reaching out to participants. So about 177 of those were replaced because we couldn't reach them after more than 6 attempts. And then sort of others were replaced because they were sort of no longer eligible, because they were no longer partnered, various things like that. So I think given the constraints of, conducting a phone survey under COVID, I think it was, a fairly reasonable response rate. I think, given that, it's just important to note that obviously, there may very well be differences between, participants in the randomized control trial who reported phone ownership versus families who did not own a phone. So they might have said, oh, you can contact me, but you'd have to reach out to my neighbor or to the local leader. So obviously those who own a phone or own multiple phones might be in a different financial situation than others. And so there might be characteristics that are different, and those, because it was a phone survey, we weren't able to capture. I hope that helps clarify.
Great, thanks, Kate. And I just wanted to quickly acknowledge that we have many colleagues from the Prevention Collaborative, Laurie Hayes, who've been interacting with people, answering some of the questions. Thanks, Laurie. And we also have Kathy, Dominique, and others, thanks. And I also want to acknowledge the presence of Fidel, who's got the hand raised. Fidel is the Executive Director of RAMREC. I think we owe you that part, so you can tell us what you have to share. And thanks for being here with us. Fidel, if you hear me. Okay, great. Fidel, your hand was up, maybe by mistake. Can you hear us, Fidel? Okay.
Hello?
We can hear you, Fidel. Go ahead.
Okay. Thank you, Rita. I just wanted to react about one of the comments in the chat regarding the curriculum, the Indashikirwa and Bandebereho curriculums. I was saying in the chat that the two curriculums are different because the Bandebereho curriculum only involves fathers' involvement in maternal, newborn child development and couples' healthier relationships, free from GBV, and the beneficiaries are men aged between 21 to 40, so while the Indashikirwa was only focusing on GBV, and the beneficiaries are different, but also the curriculums are different, and the targets are also different for both curriculum. So that's what I wanted to say. Thank you.
Great, thanks, Fidel. Always good to have people who are directly involved in the work with us to clarify and share their thoughts. I'll have the last question of clarification before we go into the deep discussion questions. So Alice's question says, really interesting work, and like everybody, we appreciate the work that we've done. So she wants to know if there were also polygamous relationship in these communities, and if so, how does the program work with these or with multiple other partners? I'm not sure who can take the question. Feel free to share the questions among yourself.
Thank you, Rita. The polygamy in Rwanda is not a general culture, but in Musanze district, the polygamy is obvious in the daily practices. And during the recruitment of the parent or men who will join the program, we give the floor to choose among the 2 or 4 wives. We pick one with the selection criteria, and we bring the one in the group education. And if you choose to bring one, you are not allowed to bring another one and then another one. You remain with the one maybe who is more preferred than others. But we realize that at the end of the intervention, the men are looking to legalize the marriage, even if it is a bit complicated, because when we are engaged in more than one wife, but in the intervention, we focus more on men, and they brought in the group one among the 2 or 3 wives on his preference.
Thank you, Emmanuel, for taking the question. So I'll keep an eye on the chat to see if some people want to voice their questions, but let's move to the questions where we need to discuss. And I know there was some question from Jill earlier, but there is another question. I know that the work is focused on the violence part, but in the long term, it will be very interesting to see if the improved parenting behavior have an impact on children's development. And that question is from Disa. And I want to say there is a follow-up question to that from Jill, asking if there is any data on reducing violence against children. So if you can take the 2 questions at the same time, the one from Disa and the other one from Jill. So the first one was directed to Kate, but feel free to, complement each other's responses.
Sure. Yeah, maybe I can start and Emmanuel could jump in after as well. So, in the earlier rounds of the RCT data collection, we did collect data on violence against children, which I shared a little bit about at the start. For this COVID phone survey, we did not ask about, use of violence against children. The only sort of indicator we had was, increased frustration and anger with your children, which Debelina shared. But in the longer term, so we are currently in the field conducting in-person data collection on a 6-year follow-up of the RCT. So with the same participants recruited, at the very beginning of the randomized controlled trial. And that is continuing with surveys with men and with women, sort of looking at, the outcomes that we've kind of already presented on and shared and measured in the past, but we're also strengthening the focus on, can we get a better understanding of how this intervention, in addition to, reducing violence against children, might be impacting children's development, since we know that sort of multiple factors, sort of the violence prevention, preventing, violence against women and children witnessing violence, promoting parents' engagement with their children, are things that are likely to promote sort of healthier child development. And so we are in the surveys with parents asking particular questions about their parenting practices, as well as questions about, one index child. And then we're sort of complementing that with direct child observations. So looking at several domains of early childhood development, sort of social and emotional learning, sort of, emerging numeracy, sort of cognitive development, using the Adela tool, which has, previously been adapted and used in Rwanda. And so we're doing that with a sample of about 800 children. So we're really hoping in this next phase of the RCT to have a much, deeper understanding of what the impact has been on children's early development. And I think we've heard, in addition to the sort of parenting practices, we've heard, testimonies from participants sort of about very direct impacts also of the, intervention that's currently being scaled up on, even children's, nutrition and things. And maybe Emmanuel, you could share a little bit more about sort of firsthand direct experience and what you're seeing.
I don't have much to add, but what we realize that is while we are working with the couples, the intervention impact also on child development. Maybe we will be having the data, the quantitative data from following RCT, but in meanwhile, when we are collecting the qualitative data, parents said that this model impacted on the child development. Parents are avoiding to beat the children. They are improving nutrition at a household level. And even because we are tackling the issue of unpaid care work, the parents said this program impacted also on economic of the parent at the household level. All those things combined, they are impacting on child development in general, but you will be having the data from IDELA during the RCT findings for the next phase.
Great, thank you so much both for sharing the responses. So we have another couple of
Sorry,
questions.
if I could jump in, Rita, sorry to interrupt.
Sure.
Just on the question, since it came up around in this particular survey, as Kate was mentioning, we didn't ask about specific violence use, but we did have a question around whether respondents were experiencing increased frustration with children. And, we looked at this particular question and sort of looking at controlling for gender, age, and, a couple of other factors. We did see that actually the treatment status was a significant predictor. So control group respondents were twice as likely as Bandebereho respondents to say that they were experiencing increased frustration with children. So that was just something that came out of this survey, which, as Kate mentioned, was fairly, limited in its scope around specific measures of VAC. But wanted to add that in there, that even in the survey, we did find that couples who had undergone the Bandebereho program did experience less likelihood of being frustrated with their children. So yeah, thank you. Thanks, Rita.
Great, thanks Debolina for adding. It's clarified, it's clear. So I have a question, actually two questions that are kind of related, and maybe Emmanuel would be well placed to answer that. So Jill was asking about how to most effectively train community health workers. As he said, he was not finding a lot of solid evaluation on that. And there is a kind of related question from Laurie to Emmanuel. Did you have any ability to choose among the community health workers after the training of who would go on to be delivering the program? Facilitators' ability is very important, as she mentioned, and I agree. And some people just can't do it well, even with training. So what's your take on that? Emmanuel, and then Kate Debolina-Kani.
At this transition to scale model, we don't have a choice to choose X, Y community health workers because it is a government structure. We work with all community health workers as it is figured out in the government structure. We realize that some of them are very strong, others are not very strong, but we tried to organize a refresher training in order to build the skills and capacity to deliver the program. But with this we are developing a scale-up strategy with the Ministry of Health, Ministry of Gender and Family Promotion. Now we raise the issue that some of the community health workers are not very strong. And now we are allowed to select among the 4 community health workers who are busy at each village of Rwanda. We can choose one who are strong, maybe based on education level, maybe based on the age of community health workers, because some of them are elder, are somehow the age of them are more advanced. But for this transition to scale, we don't have a choice. We work with all community health workers as it was given by the Ministry of Health.
Great. Thank you, Emmanuel. Just to acknowledge some great reflections from people who I know work on Bandebereho. Jean-Baptiste, we appreciate your comments in the chat box. People feel free to check that out. Another question directed to Kate. So Tarisray, sorry if I mispronounce your name. If the approach would have been different had there not be, you want to say, would the approach be different if there were no restrictions? And they're thinking about those who may not have access to funds, who may be the most vulnerable in the issues being addressed. Maybe, as they say, it may not be an issue there, but the follow-up question is about, it would be interesting for them to know if there was difference in the numbers, unreachable in the intervention versus the control. And that is related to Kate, but anyone here, I think, can address that. Feel free.
Sure, thank you. For the second question, I don't have that information readily at hand, but I can try and pull it up before the end of the webinar. But on the first question about would the approach be different? Yes, I mean, if we weren't dealing with a pandemic and restrictions on research that could take place, as well as our own desire to ensure the safety and the health of the enumerators and the respondents, we are interested to know the impact of all men and women who are enrolled in the study, so the full sample of about 1,200 couples, and that is what we are doing now, interviewing all those who are eligible and interested to participate in the follow-up study. So I think the phone survey was obviously a kind of result of the situation in which we were placed in the pandemic, and following government guidelines, and wanting to understand the impact, but also recognizing that the most vulnerable are not going to be able to be reached in this way. So yes, we definitely recognize that. Maybe for the question about the differences in sort of refusing to participate or those who could not be reached, I could try and pull something up prior to the end of the webinar to respond to that.
Thank you so much, Kate. And we can share more resources as we get them with the takeaways. Let's move a little bit and give Kate some time to breathe a bit, and probably Debolina can address this question from Dorothy. How did the improved couple relationships improve social cohesion in the community, if you know something about that?
Thanks.
Okay. Okay.
I would say that that's a bit of a depending on sort of what we mean by social cohesion, and sort of how we are thinking about communities coming together and there being a feeling of cohesion in the community, that might be answered differently. But my initial sense of responding to that question is that I think in general, sort of reduced having improved relationships at the household level, and having sort of potentially reduced instances of violence, or having just more strengthened relationships and more communication, and sort of more positive ways of responding to stress that does not lead to an increase in frustration and violence, is also hopefully contributing to greater cohesiveness at the community level, that just by reducing violence at the individual and the couple at the household level, that's potentially contributing to sort of a more positive environment at the community and societal level as well. But specifically, when we think of social cohesion, how these findings relate to that, I'm finding it a little bit difficult to sort of relate it, just because of sort of how restricted our survey was. And sort of, as we've mentioned, we only had 15 or 16 questions very specifically about the experiences of being at home during the confinement period, and sort of how that relates to the business as usual. So yeah, I think we can probably extrapolate more from the findings in the report, and given more time, maybe I can reflect on that a bit more. But yeah, it's a little hard to relate it too much to social cohesion, given that we did not really ask questions to measure that in the survey.
Great, thank
in
you.
addition to that, even the name of Bandebereho in Rwandan context means a lot. It is meaning that the role model, when after model, and most of the participants are managing the conflict at household level, at community level, and sometimes they are elected in different for managing the conflict, the resolving. When after graduation, the participants become a role model and they are playing.
Sorry, it looks like we're having trouble hearing you, Emmanuel. Maybe we can come back to you later. Okay, if people can hear me, I hope it's not my connection. So let's go to another question and we'll come back to you, Emmanuel, sorry. So Julia has a question and she asks, in relation to facilitators' effects, so to speak, how would you feel about measuring, testing community health workers' adherence to the instructions and training? If any of you, Kate or Debarina, can take that as we wait for Emmanuel to get reconnected.
Sure. I mean, in lieu of Emmanuel, I can kind of respond that sort of, yeah, in light of Lori's question and this question, sort of, you know, how well can the community health workers, given that we can't sort of select them, deliver the intervention with quality, and how well are they adhering to it? Those have been really critical questions. So, you know, we've done a number of things sort of assessing directly at the end of training, you know, the skills of the community health workers based on sort of, you know, internal assessments we've developed. Then, you know, we've been collecting data, monitoring data around, you know, how faithful are they to the intervention in terms of following the curriculum, doing the sessions in order on a weekly basis. You know, are they recruiting the correct participants? Are they, you know, sort of reporting on time? All of those things we've been following very closely. And we've seen that there has been a really high fidelity to the intervention in terms of, you know, following all those things and using the curriculum. We've also developed a number of tools, sort of observation tools. So I think Emmanuel was starting to share a little bit in the presentation around doing session observations. So RUMRC staff together with the community health worker supervisors who are based at the health facilities, and sometimes with the sort of in charge of gender or ECD at the district as well. We developed sort of a 21 measure little tool and scale to sort of assess factors that we think, you know, that the team involved in developing and implementing Bandebereho over time felt were really critical to, you know, the fidelity and the quality of the intervention. And I think that ranged from, you know, using the manual, sharing the information as it is in the manual, to like facilitator dynamics, to, you know, how much are women speaking up in the groups, different things. So we also collected all of those session observations. And so there we saw, you know, fairly good quality and fidelity indicated from those session observation tools as well. And I think, as Emmanuel was saying, there's some variation in the community health workers. And one of the things that we have done under this model also is to pair them together so that it's not reliant only on one facilitator, but on two facilitators who can work together. But yeah, definitely monitoring and sort of following how well it's being implemented and whether it's being done with quality and fidelity has been a really critical part of the transition to scale phase. And I think incredible work has been done around that, given that I think Emmanuel had some internet issues with the slides and things during the presentation, but just to say that all of this has been undertaken under COVID. So, you know, the training of the community health workers, the implementation of the sessions, the monitoring of it, But yet we still have seen quite high degree of quality and fidelity.
Thank you so much, Kate, for stepping in. And I know we have questions, and I know we cannot go through all those questions now, but we're happy to have some follow-up with individuals and share as we share the key takeaways. So one last but one question from Laura. She wants to know, weren't there any other interventions in the 5 years until the latest research? So we can, be certain of the sustained impact of the initial program implementation. If you can talk to that, Kate or Depolina, any?
Sure. I mean, certainly participants may have been reached by, other interventions over time, but I think the importance of using the randomized controlled trial, study design is that we're able to kind of, more effectively assess whether it is the program implementation that's had the impact and, over time. And one of the things that, in the COVID study, we weren't able to kind of collect information on this, but in the kind of ongoing 6-year follow-up, we are collecting information about whether people have participated in other interventions. So we've also identified in particular, in 2 of the districts that where, Ramrick and Promundo have been, either scaling up this approach or implementing other approaches through, for example, like the Parents' Evening Dialogues in Rwanda. We are capturing that information also to be able to, in this longer term, more intensive 6-year follow-up, be able to assess whether that is having any impact on the findings as well.
And just a quick line to add there, we have this table in the report to sort of describe in more detail, but if you look at at the demographics of the difference between the control and treatment group, even for this limited survey, they are very similar on things like age, the number of children on average that they have per household, and other, even their distribution around locations across Rwanda. So generally on other features, the sample between the control group and the treatment group is pretty balanced. And so, yeah, it just helps make it a bit more give a bit more confidence to assign some of these differences to the program and not to other factors, but just wanted to add that in there.
Thank you so much, Depolina. And we almost at the top of the hour, and we really, really appreciate that there are questions and engagement. And unfortunately, we can't go through all these questions. I wanted to ask people to stay a bit for a poll that we're going to launch to do, just we owe that to our speakers. They want to have some of your ideas. So I'll ask my colleague to launch the poll, and sorry to put you on spot, but please know the speakers need your responses before we close. There we go. Did you find this webinar useful or relevant to your work? Feel free to choose your answer. I think we have 4 questions, so that should be quick. Did the webinar inspire any change or ideas for your own work? That's gonna be useful for not only for the speakers. We can even keep this to the 2 questions, I feel, if that is okay with you, Kate and colleagues. Great. Okay, we have our answers. We're not gonna share that here, but this will be helpful for the speakers to share in other forums. Well, we're at the top of the hour, and yeah, thank you. A big thanks to everyone who participated, a big team that was supporting this in the background, Ruti, Muhammad, Juliana, and everybody who contributed to preparing this. Great thanks to the 3 speakers, Kate, Emmanuel, Depolina. Emmanuel, I'll connect with you to tell you what was the end of the webinar, and we really appreciate that you shared. And on behalf of the Prevention Collaborative. I need to thank all of you. Great speakers. We are staying connected with you, and we'll read the report and we'll, reach out. And if you want to stay connected with us, we have a slide there on how to stay connected, and we'll reach out with the key takeaways soon. And please stay alert for our other events. We have a virtual coffee that is coming. And if we have a link, we'll put it in the chat box on July 7th. And thank you so much all. Thanks, Kate. Thanks, Debolina again. Thanks, Emmanuel. Thanks everybody who contributed. This was really, really interesting. So you have the virtual coffee invitation. Feel free to join and stay engaged with the Prevention Collaborative. We appreciate.